Starting, all attendees are in listen-only mode.
Hello, everyone, and welcome to EBFA's September webinar. My name is Sarah Harper, and I'm the Administrations Coordinator at EBFA. Dr. Emily is currently in transit back to New York City, couldn't be with us this evening. I would like to thank you all for taking the time tonight to join us to get some great free education. Tonight's special guest is Dr. Perry Nickelston of Stop Chasing Pain. Welcome, Dr. Perry.
Thank you very much, Sarah, for having me back. It's always great to do these webinars, and I anticipate a lot of fun. Thank you very much.
You're very welcome. Thank you. We are going to get started here very shortly. At the end, we will have a couple of minutes to take your questions. And I'd like you to remember that if you don't get a chance to have your question answered, you can simply go to our YouTube channel where we post all of our archived webinars. You can leave your question in the comment section, or you can send Dr. Perry an email. I will now turn it over to Dr. Perry. The floor is yours.
Great. Thank you very much, Sarah, and thank you all very much for tuning in. I do apologize if you were tuning in earlier in the week. Unfortunately, I had Mother Nature interfered with my webinar plans that night. In northern New Jersey, I had a tornado rip through my area and a hurricane, so I was a little indisposed that night. So I promised to make up for it this evening. And I'm going to give you my email address in the beginning and also at the end. So if you have additional questions, you can certainly send them to me. It's stopchasingpain@gmail.com. That's stopchasingpain@gmail.com. And I'll get back to you pretty fast. So I'm going to be talking about 30 minutes here on a topic that I'm really passionate about. And I can tell you that this is only scratches the surface of some of the stuff that I teach people, because I actually have a 2-day course in a 1-day course where I go over this in extreme high detail. So keep in mind, this is 30 minutes worth just to give you kind of a look inside my mindset and my world when I'm dealing with helping patients. So my background is working with clients that have very difficult, chronic, hard-to-fix conditions. So I'm the kind of guy on the bottom of the totem pole that you see after you've been to a lot of other places. And I use this Primal Rehab and Reflexive core stability work quite a bit, and it can make some significant and profound changes in chronic pain. And I hope to open your minds up just to a few different ways of looking at the body. And Sarah's going to be kind of flipping through the slides here and scrolling up and down a little bit. But if you see the first slide here, you know, it's one of my favorite pictures, and that just ties back into some of the neuro-developmental things that I teach people in regards to movement patterns. So that's a Turkish get-up pattern on the right, kind of midway through the Turkish get-up, and it mimics some of the patterns that we learned to get through from lying on our back and being able to stand, walk, and move. So part of the primal rehab for me is taking you back to your primal roots where we all learned how to move, which is starting on the ground, on our back, only being able to look at stuff and turn our heads and grab things. So if you go to the next slide, this is one of my favorite quotes that I use all the time. I treat a lot of dancers, and dancers are the epitome of movement. And Martha Graham has a great quote that says, "Movement never lies," and it's true. So no matter what your past history or things that you may have even forgotten or kind of in your subconscious from prior episodes of pain, if I get to see you move, I get to see how comfortable you are with your body and how much body awareness that you have. So I can see just how stable you are. So a lot of people think they're very stable. They're very strong, or very mobile, but it doesn't mean that they're actually very stable. And I pretty much tell everybody that I think that everything is an underlying stability problem, a stabilization issue, even after you have a mobility dysfunction. And hopefully by the end of this, you'll kind of see that from my standpoint. So my evaluation always goes down to movement. So with the next slide, I firmly believe that everybody has a movement dysfunction. They just don't know it yet. So until I put them through some movement patterns and they can experience just how difficult or challenging moves can be, especially when you go down to the ground. So the further you get down to the ground for some of these assessment movements, the harder it is for people to do them, because they have to pull from that central core stability or that reflexive core in order to make those movement happens. They can't cheat on the mirror muscles that you see or the big powerful muscles that they rely on all day long that are typically being overused because the ones up underneath, kind of underneath the hood, I say, are really not working. So the only time that people really know they have a movement dysfunction with the next slide, as you'll see, is that they come in and they say, something hurts. If something hurts, then they think they've got some kind of dysfunction. But pain is usually the last thing to hit you, not the first. And with the next slide, how we know that they have a problem and movement dysfunction, not necessarily pain yet, is that they have increased fatigue, a lot of tightness, spasticity, trigger points. Their activities of daily living are impacted, small things at first where they can't really take the stairs like they used to. They can't bend over and do things like they used to, but then all of a sudden it kind of is like the common things of life for them. For athletes, they have decreased in durability. Maybe they're on the injured list a lot. They're popping pain relievers like candy, and then they just think of that as normal. Extra tightness, stiffness, aches and pains, and you'll see later that I think tightness and stiffness is an underlying neurological compensation for a lack of stability. And they have a lot of joints that begin to lock down. So ankle joints, hip joints, thoracic spine, and upper cervical are typically the main joints that begin to lock down on somebody who does not have central core stabilization. And it's that old adage that some of my mentors say all the time, that you have to have proximal stability, which means core stability, if you want to have maximal distal mobility. So if you have mobility problems outside the core, then my contention is that your core pretty much sucks, that you can't control your stabilization in the middle, so your body locks down your joints to make you stable. So to help these mobility problems long term, you need to go back to the intrinsic reflexive core. And then you have poor performance. So a lot of times people just can't do what they used to do. So with the next slide, when we're dealing with primal patterns, I'm just going to go through subsystems and chains. And these are just things that every living human being has to do. We all have to push stuff, pull stuff. We got to twist and rotate no matter what we do. I mean, just going in to pick up your car keys that you left on the counter, you got to rotate. And you need to lunge, squat, and bend. And gait, obviously, is kind of a combination of almost all of those. So gait is something that we translate over into rolling patterns that I'll show you later, because gait is actually just rolling patterns standing up. So with the next one here, what does reflexive core stability mean? To me, a lot of people train the core. There's a big buzzword about the core means. I'm concerned about the core that's supposed to be working without you thinking about it. Because trust me, when you're out during the day, you're not going to be thinking, okay, I have to brace my transverse abdominis, I have to posteriorly tilt my pelvis, I've got to pull in my abdomen and brace. Nobody does that. You're not supposed to do that. That's supposed to turn on automatically at a subconscious level, and that's why a lot of these wonderful programs for core stabilization or core strength don't carry over to real life, because you can spend a lot of time on somebody in an office cueing them or giving some proprioceptive feedback by tapping their core or helping them tilt their pelvis back or brace and engage before they lift something. But out in the real world, when you have to think a split second, even with a sneeze or a cough, that stuff's got to brace before your brain even thinks about it. And if it's a little bit slow to show up, that's where an injury happens. So reflexive core stability is basically a neuromuscular response strategy. It's got nothing to do with strength. Strength does not carry over to reflexive core stabilization. This needs to be subconscious. It turns on like a light switch when you need it. And we need it to be instant, and we need it to be adaptable, but not rigid. So people that have a poor reflexive core stabilization are very rigid, they're very stiff, they're very tight, and they don't move very well, and they lose mobility. So it's kind of a feed-forward mechanism where in order to prepare for movement, your intrinsic core needs to go first, and a lot of times when that's gone, people brace and they have a habit of using the external core. If they've been in pain, if they have had injuries, external stress, all those things help people to stay rigid and in a kind of a self-protective mechanism not to let themselves go. So with the next one on here, when I said about strength, It doesn't transcend. There's a lot of guys that I see who are extremely strong in their abs, and they look fantastic in a mirror, but they can't do anything with a rolling pattern. They can't take a half kneeling chop and lift when I try to challenge them a little bit. So they're dysfunctional because it's too slow to activate, and your stabilization begins to suffer, and you cannot manage forces from within your body, which is the ability to generate force from the inside out, to take the central core and deliver it through your arm and your leg. Like if you want to punch something, you want to kick something. So we actually use too much of our shoulder joint and our hip joint when we move through, and not the core. And we also have to be able to control the external environment, the ground pushing back up towards us when we impact it, or somebody coming at us the other way and pushing us or moving us when we don't expect it. So a lot of my testing that I do is reactive when you kind of don't know that I'm going to be doing it, through perturbations that I'll go over later. But I really want to challenge you when you least expect it to see, can you hold it? Can you uh, compensate after you have an outside force that comes into your comfort zone? And the safety and the efficacy or efficiency of movement is really what it's all about, because it's not so much that the people that I see really move well, but they're very high-end compensators. So when I look at the intrinsic core, there's a hierarchy that I look at. So with the next one, this is basically neurodevelopmental kind of one-on-one stuff of looking of how we all developed. Intrinsic core is basically looking at your inside for your intra-abdominal pressure, which I'll show a little bit more later. That's your diaphragm, your pelvic floor, your transverse abdominis, and your multifidi. That rules the road. If that system is defective, all the other systems are going to try to come on board to make you stable. And then the next core system up is the deep core line, which I'll show you pictures of as well. That ties in a little bit more to your inner thigh, your deep neck flexors, posterior fibers of your internal oblique, and some of your deeper muscles for your quadratus lumborum, your psoas, and your iliacus. Then your arm lines form. That's your ability to actually reach for things, move your head, reach out, grip something, and pull it back and put it in your mouth. And then your subsystems develop. Subsystems go from opposite shoulder to opposite hip, on the front of the body and the back of the body. And then we look at rotations and we look at gait on being able to control the systems from a single leg stance to acceleration and deceleration. So with the next slide, I'm going to go over some hidden signs of instability. If you see any of these signs pop up on somebody, that's a telltale sign that they have a reflexive core stabilization dysfunction, and you need to break them down and regress significantly before you progress them forward. The one is the jaw, and I've written an article on this called The 5 Hidden Signs of Instability for the Boston Sports Medical Group that's online, and also Dynamic Chiropractic. If somebody clenches their jaw and they grit their teeth when they're doing some of these easy assessments that I'm going to go over, they have a centralized reflexive core stabilization problem. So they squeeze their jaw because they're trying to get some strength from the jaw. The other one is the diaphragm. If you hold your breath through any of these assessments, you have a core stabilization problem. I tell athletes or people that work out, you can hold your breath if you're trying to deadlift 350 pounds, but you're not supposed to hold your breath if I'm having you do a plank. That's a no-no. The other one is clawing with your foot. If you have somebody do a single leg stance and their toes claw the ground, the tendons on the top of their foot pop out, or their toes do anything but relax, that is core stabilization problem. They're trying to hold on for the glute max or something higher up in the lumbo-pelvic hip complex. The foot should be nice and stable and still. The other one is gripping. If you're holding on to anything for dear life when I'm having you do something like this, say for instance I'm having you do a chop and lift, holding on to a dowel rod, and you're gripping that rod like you're going to fall off a cliff, that's a dysfunctional core, because a grip will increase your rotator cuff engagement and make it stable up top. And the last one you'll see in high-end athletes a lot, the face should be totally still. If you're doing these movements and you bite your lip, you grimace, you move your lips, or you change anything in regards to what your lips or your eyes are doing and your face, then that's intrinsic core stabilization problem. And the way that I can prove that is that if you have an athlete do a very simple movement, like a half kneeling chop and lift, and you see them biting or grimacing or doing anything with their face, then you tell them not to do that. And you watch that they don't do it. And then you retest them. You'll actually see them begin to fall apart. A chaos will begin to happen, and then all of a sudden they can't hold and stabilize anything. So you can do whatever you want with your lips and your face when you're doing a power clean. But if I'm doing a single leg stance and you're biting your lip, the first thing I know is that your core absolutely sucks. Okay? So if we flip the one in here to the next one, this is basically what I'm going by. The neurodevelopmental pattern of this baby on the ground. No matter how you look right now, no matter if you're world champion on the football field or you're somebody who works at McDonald's, you all started at the same place, down on the ground, sticking something in your mouth, looking over, trying to get it. So with this picture, it's the legs moving, it's the arms moving. You're starting to get some of your core stabilization there, but the head looks where you want to go. Your eyes track it, and then your arm reaches for it. So some of these neurodevelopmental core stabilizations that I look for, the neck is intrinsically tied to how you grip things and how you move from center mass. So if this baby wants to actually get over towards that toy, it's going to learn to have to actually roll over. And that's the next slide, where we get into rolling patterns. So you got what we call a punctum fixum, where there's a fixed point in the center mass of your body, and you need to be able to roll over using that X pattern. So in the front of the body, that's the anterior oblique system. In the back of the body is the posterior oblique system. And if you look at this picture on the right with Bart, the slingshot is pretty much what that is. So the slingshot is the center mass on that X on this guy's abdomen and on his lower back. That's where the stability has to come from. So if that is stable, he's going to be able to maximize the use of his arms and his legs, which is the elastic band on that slingshot. If that base is not stable, and like the slingshot is moving all over the place at the bottom, he's not going to be able to maximize the power output for his arms and his legs. And just like that slingshot, you're not going to be able to launch it. So with the next one here, the intrinsic system I work with a lot. This is the diaphragm, the pelvic floor, transverse abdominis, lumbar multifidi, and I add in these other things as well. The deep neck flexors, posterior fibers of the internal oblique, in the jaw. Most people you're going to find their diaphragm is upregulated, which I call facilitated. In the DNS world, some of you guys may be DNS people or have heard of it, they will say the diaphragm is inhibited. We're saying the same thing, it's just different verbiage, all right? So basically the diaphragm does a lot of work for the transverse abdominis, the multifidi, and the pelvic floor. Very often, the transverse abdominis and the multifidi are inhibited, which means they don't activate well, they're slow to engage. The easiest way you can determine that is if somebody has a delayed response and a typical push-up pattern. That's a classic TBA, delayed response. Or if you even want to do a muscle test on the transverse abdominis, there's many different ways you can do that. You can look that up and see if the transverse abdominis can engage. But if you have any part of this cylinder complex that is not working, this should form your barrel. So if the diaphragm is overworking, your transverse abdominis is not, and your multifidi are not, then you are already at a disadvantage for core stabilization. And my contention is I'm not going to progress you in anything until I begin to reset this. The pelvic floor, I can do a whole seminar on the pelvic floor because the pelvic floor can go either way. Very often it's inhibited, and Kegels will help improve that. But very often the pelvic floor is facilitated, which means it's already working too much. And if you do a Kegel on a pelvic floor that's facilitated, you will make these people way worse. And I can tell you from my experience, when you assess muscles of the body, the deep neck flexors and the posterior, the fibers of the internal oblique are very often inhibited on people. So most of the time, when I release the diaphragm, I need to go back and make sure that all these other muscles below the diaphragm are actually able to work. That's the first thing we reset. Then if we go to the next slide, this is the deep muscles of the core. This one is the deep subsystem. This is from Thomas Meyer's work for anatomy trains. And you can see in the picture here, you've got the deep neck flexors in the front on the left, and you've got your adductors in the inner thigh, and you've got your psoas really accessing your diaphragm on the back part of your body, the quadratus lumborum, the deep muscles in the back, your obturatus and your piriformis, which are actually the external fibers external portion of your pelvic floor, and then down into your popliteus and posterior tibialis in your foot. So one of the things that I look for on somebody, one of the quick assessments that I do is I have you put your feet together, see if you can touch your chin to your chest in a standing position. If you can't touch your chin to your chest, or you can't touch your chin down to each one of your collarbones, maybe you have some core stabilization issues where because you're tight, because your core is weak and you're standing up, your body's not stable, so it's kind of tighten up the muscles in your core not to let you get there. One of the things that I'm going to do to see if you have a core stabilization issue or a reflexive core issue is I'm going to have you squeeze something between your knees as you're standing. So put something between your knees, and that'll activate your inner thigh, which will increase the intra-abdominal pressure in your abdominal region, and you can very often get full range of motion in your neck. So that's a telltale sign, is if you contract something between your inner thigh and your neck moves more in a standing position, you have an underlying core stabilization reflexive core problem. So you need to go and get down on the ground and start to work the core. I'm going to breeze through these next ones pretty quick. The next one is the arm line. That's the one that's going to relate to how your head moves and affects your grip. So very often people will have a grip in their hands that are become inhibited and do not work when they move their head. So one of the things that I have people test for is, does the grip strength change when somebody rotates their head? So if you have a grip strength measuring device and you want to have them squeeze down, have them turn their head and see if it changes the grip strength. If it does, then you're dealing with some deep underlying core issues. The next slide is the anterior oblique sling. This is your body's ability to actually roll over or do gait. So this is something where I have you down on the ground and I see if you can roll from your back to your stomach. Very often people can't do this because if you look at the picture on the right, the center core, the rectus abdominis, the transverse abdominis, and your obliques, internal and external, are very often not working well and not sequencing well. If that's the case, people will overuse the hip adductors in green, and they'll actually use a little bit higher up in the chest and pec. And if you look on the slide on the left for the javelin thrower, if those center muscles don't work down on him, he's going to overuse his pec minor and he's going to throw too much with his shoulder because he doesn't have intrinsic core stabilization in the center of his body. The next one on the next slide here is a posterior oblique sling. This is a classic. This is your ability to control gait going forward. Most people have glutes that are inhibited and latissimus dorsi muscles that are inhibited that don't do well. If those two muscles do not activate well when you want to run out of the gate, the only thing left over to hold you is your thoracolumbar fascia. So the thoracolumbar fascia becomes very, very tight, very, very restricted. It's extremely difficult, if not impossible, for somebody to roll on a rolling pattern from their stomach to their back without this subsystem. So if you have a problem rolling from your stomach to your back with a rolling pattern, you need to look at the thoracolumbar fascia as being too tight and not being able to use your lat to pull you back over when you use your arm to go back or when you use your leg to bring you back with a rolling pattern. I've written an article on the thoracolumbar fascia quite a bit, but that is the linchpin for core stabilization in the back. Next slide. The lateral subsystem is my favorite because most people have frontal plane stabilization issues. This is what I'll work you up to after we've gone through all the other ones. This is something where you'll typically have inhibition on the glute med on one side, and then the adductor on the same side, and the opposite side quadratus lumborum. These guys have to work as a functional unit. All right. So what you're going to be able to see in through here, oftentimes with a single leg stance, is the glute med is inhibited, so the hip pops out to the side. Then you need to look and see if the inner thigh is overworking or the opposite side quadratus lumborum is overworking, and that's typically the case. So when we get into some patterns later on with some chop and lifts, I'll show you how we can work around that. And the last one is the deep longitudinal subsystem. This is the one, this is the final stage of neuro-developmental patterns. This is where you can run and you can control feed forward, being able to accelerate and decelerate. This one comes into play all the time when somebody has a sacroiliac issue or a subluxation problem that you can't get rid of in the pelvis. The biggest dysfunction that you'll see in this pattern here is you're going to have a locked up ankle. a locked up fibular head, and usually an inhibited biceps femoris. So this is something that we'll get through when we get into some single leg stance patterns. The following one is just a brief overview of the diaphragm and why the diaphragm is so important. If you look at the picture on the right, that diaphragm is a powerful sucker, and he's going to attach to almost every single one of these muscles that I went over before. So he fascially attaches to your transverse abdominis, your psoas major, your quadratus lumborum, but he also attaches to your thoracolumbar fascia internally as well. So if your diaphragm is overworking or upregulated, all these other muscles that you see down here can be inhibited in the core, and I find that a lot. Where the TVA doesn't work, the psoas doesn't work, the quadratus lumborum doesn't work. The only thing hanging on is the thoracolumbar fascia and the diaphragm. So for those that can manually release the diaphragm, you definitely want to release the diaphragm, but then go in afterwards and then activate all those other different muscles that you see down here, and you can see a significant improvement in reflexive core stabilization, their ability to brace, in particular the obliques. So with the next one here, you can skip that, I already did that. Thanks. So one of the things when we do the reset is after I release the diaphragm and reset the intrinsic core, typically what I'll have somebody do is give an abdominal brace to now turn on the transverse abdominis and activate the lumbar multifidi with a little bit of a low back arch, and then teach them some diaphragmatic breathing. Typically what's called Lois breathing, which is by a mentor of mine, Lois Laney, who's very brilliant. I've done a podcast with her on Stop Chasing Pain on iTunes talking about breathing. But breathing in through your nose and out through your nose, just to regulate diaphragmatic breathing so you can expand your abdomen and expand your rib cage. And I usually will cue people to actually put some fascial tape, some rock tape I use, or kinesio tape or KT tape along your thoracolumbar fascia to help relax the fascia and give somebody proprioceptive feedback and being able to expand their rib cage so they can feel the posterior part of the rib cage and the posterior fibers of their internal oblique. So with the last slide, I'm going to go over here. These are some of the things that I'll do with people. So if you scroll to the top, I went over this before, is that if you have a deep longitudinal line dysfunction, this is the quickest way to see it. Have somebody, one, do cervical range of motion in their neck. Can they bring their chin to their chest, bring their chin to their collarbone? If they can't do that and they squeeze something between their knees and they get further, they have a reflexive core, intrinsic core stabilization problem. The other one is the toe touch. If you bend over and you try to touch your toes and you can't get to touch your toes, then you squeeze something between your knees as you bend over and touch your toes. If you get further, touching your toes, squeezing something between your knees, that's a telltale sign that you have an intrinsic core stabilization problem and you need to work on stability. Not so much mobility. Yes, you can release a mobility problem. So if something is locked up, you release it, but you must back it up with some stability training in the core. So what I'm going to do in my office is I'm going to put somebody through ground up. We'll do rolling patterns down on the ground, rolling from your stomach to your back and your back to your stomach. Then I'm going to transition you up into what's called a diagonal side sit. You can look this up on the internet, and I've written an article about this as well. That's the transition zone between being down on the ground and being able to actually sit up. And the other one is a rocking pattern, where if you see a baby trying to get ready to crawl, they actually will rock back and forth, sitting back on their hips and coming forward, back on their hips and coming forward. This primes your engine of your pelvic floor and your transverse abdominis. It's an extremely powerful core development exercise. And then we'll do crawling patterns. Opposite arm, opposite leg, move at the same time. Fantastic training exercise. Contralateral patterns I can do, lying on your back as well. So I'll bring one knee to the opposite hand and back and forth 50 times. The half kneeling chop and lift, I've written about this as well. There's an article I've written on the internet that you could just type in my name and half kneeling chop and lifts. And that's the one where I'll have somebody get into a half kneeling position. They'll hold the dowel rod out in front of them, and I'm going to add perturbation, which means I'm going to tap the top of the rod on one side, tap the bottom of the rod on the other side, and see if they can control it. see if they can stabilize it. They don't know when I'm going to hit it. They don't know when I'm going to let go of it. That's testing reflexive core stabilization, and I have them train with that before I actually have them do any weight pushing up or pulling down on a diagonal pattern. And the last one is the standing X pattern. That's gait. So I'm not going to have anybody get up and do any kind of standing corrective exercises until you can master every single one of these down below. From rolling, and you master them all the way up, and you've earned the right to do a standing X pattern, which is human gait. All right. So the big takeaway from here is when you're looking at reflexive core stability, it's much better if you can see these in person, of course, but the big thing you got to figure out is, am I dealing with a stabilization problem, or if I'm dealing with a mobilization problem, a mobility problem? You're always dealing with both because you can't have one without the other. But my contention through my years of doing this and treating people all the time with chronic pain is a lot of people are doing mobility stuff, soft tissue work, foam roller stuff. They're releasing joints. They're using bands. They're cracking stuff. They're popping stuff, and stuff just doesn't hold. And the reason it doesn't hold is you don't have the intrinsic core stabilization from the center mass out. So your brain and your nervous system have no choice but to take your joints and lock them down and make you stable, whether you want to be stable or not. So in the long run, just determine how deep the stabilization problem goes, and then start to work your way up from the diaphragm out. Because if you start on the other subsystems first, you may make some positive changes, but they typically won't last because you have to go and dig down to the deeper foundation. So just start to implement some of these testing strategies that you do. Read a little bit further about the subsystems. You can also certainly come to one of my courses and learn a little bit greater detail. So, Sarah, that's about it for me. I'm going to open it up for some questions. If people have any, I'll be willing to take anyone they want to throw my way, and they can also learn more information on my website, obviously at stopchasingpain.com.
All right, well, thank you so much, Dr. Perry, for your time and for sharing this great information with us. Like he said, again, you can find Dr. Perry, his workshops, his blogs at stopchasingpain.com. Actually, right now, I guess you did such a good job that you have answered any questions that people would have had, because there are no questions right now.
Oh, that's good. Well,
Yeah.
awesome. Okay.
Oh,
Well,
okay.
if
Hold
they
on.
have any, come later.
I spoke too soon. We have one question. How many workshops are being held in 2013 and 2014?
2013, I'm pretty much done this year with the Primal Rehab ones. Actually have one more left in Philadelphia at a CrossFit facility. So I work with a lot with the CrossFit athletes to help them with stability. And then 2014, I'm going to have a lot of the Primal Rehab. I'm actually changing the name of it to Primal Movement Chains, working with that. And I'm going to start to put those up on my events page within the next week or so on stopchasingpain.com.
Okay, great. We do have one request to quickly run over the single leg stance assessment.
Sure. Okay. Well, that one's one of my favorites to do because most athletes, if you want to go back to that one with the single leg stance on it, it's one right with the arm, one right below the arm line. There you go. No, a little bit further down, I think. Yeah. Nope, not one. One more. Okay. So yeah, so most people will have dysfunction in the frontal plane. So when we're trying to restore intrinsic core stabilization or reflexive stabilization, we always will go for rotational patterns first, and then we'll go to frontal plane, coronal plane. So when I do a single leg stance on somebody, for instance, this is basically what everybody has to do when they take a step during the day. So if I'm standing on my left leg there, if I'm looking at the picture that she's doing, these three muscles have to work together. These have their own very specific, unique pattern, and these develop a special way in order so you can move. So if I raise my right leg up in the air and my left leg is down, my left glute med, my left adductors, and my right quadratus lumborum have to work well in order for me to be stable. So very often this test, one of the signs that you look for is what's called a Trendelenburg test. Trendelenburg test typically means that your glute medius on the side that you're standing on is inhibited, so it can't keep your hip in, so your hip pops out to the left. If that's the case, you have an unstable lumbopelvic hip complex. So what your body is going to do is there's two other muscles in that complex that are left over. So because the glute med has some inhibition on it and is not able to do its job, your brain is going to recruit the other two muscles that can do more. So your adductors can start to work more, which typically means that you may get trigger points in your inner thigh, a lot of tightness on your inner thigh, or you may start to develop groin pulls or knee pain or pubic symphysis pain. The other side, your quadratus lumborum, may go into spasm. So you may have back pain, you have hip pain, radiation pain on the right side, all of that because your glute med doesn't work. So part of the restoration program is instead of just going in and strengthening up your glute med, okay, which everybody does, they get down and do a clamshell, they do side leg raises and stuff like that. But because these other two muscles are already working so much, you're not going to be able to get the strength in that glute med to last. It's not going to stay. So what you have to do is, when we go through these programs, is you have to go in and you have to start to release the other two muscles first. So you release the inner thigh on the left, the quadratus lumborum on the right, and then you go in and you activate your glute med on the left. And what will happen is it'll sync with those muscles together. So now when you raise up your leg, those three muscles lock in and help your sacroiliac joint. And then you have to do the same thing on the other side. So what I teach people is that if any one of these muscles in a pattern that you find as inhibited, something in the other ones that are remaining has to work a lot harder to make that happen. And then because these muscles here, all right, are not stable, they're not able to balance the lumbo-pelvic hip complex, what your body will do in order to make you stable, it'll take your sacrum and your ilium and it'll stick it together. And it'll jam it together, and then you'll end up with chronic sacroiliac issues, which is a mobility problem. But the mobility problem came because you don't have stability in your subsystem to control yourself every time you take a step. So that's pretty much what we cover in 16 hours. But it gives you a head start of there's a lot more to raising your leg up in the air than just seeing can you balance on it.
I have one more question, and then I would like to remind people if you do not get your questions answered, please feel free to email Dr. Perry. We are just trying to be considerate of everyone's time this evening.
Sure.
The question, it's more like a comment. I use NKT level 1 stuff a lot and find weak psoas all the time. Is there something bigger I'm missing?
Yes, you are. The level 1 stuff is great for that technique, but you need to level 2 stuff is where you work more of what I'm talking about here. This is not really so much NKT stuff here. This is just basic core stabilization stuff that they'll cover in DNS and many different other types of things. So if you type in intrinsic core on the internet, you're going to see these come up, and everybody's got their own way of working with it or dealing with it, different methodologies, and I think they're all wonderful. They all can have some benefit, but they're really following along the line of just a paradigm or a principle, and the principle is you need to have that system stable. However you choose to get there is really whatever resonates with you. I think everything works for somebody, but the big idea is that until you begin to work with these subsystems and that inner core, a lot of these other methodologies that people are doing might not hold as well. So they're great, but if you can take it up another notch and actually have it hold a little bit more when somebody leaves your office, that's the game plan. That's the goal.
All right. Well, this will actually wrap up our questions segment. And as I mentioned, you can find this webinar with the slides archived on our YouTube channel, and that is YouTube with EBFA Fitness. Again, thank you so much, Dr. Perry, for your time and for sharing this great information with us.
Thank you very much. I had a good time. Hopefully people enjoy it a little bit and maybe learn one or two things that can change a person's life or send them in a new direction to learn a little bit more.
Yeah, and I know that is why you're here. That's why we appreciate you so much. We hope that you will tune in to our next webinar in October when Dr. Emily will return, talking about prevention and treatment of ankle ligament injuries in the young athlete. And please remember, our webinars are usually the first Thursday of every month. We hope that you will join us on Facebook and follow us on Twitter to get more free education, comments, questions, and remember to share. So have a great evening, everyone. Thank you.
Thank you.
Bye, Dr. Perry.
Bye.